Dear colleagues, I'm delighted to welcome you to today's lecture in the Ethics in COVID-19 Pandemic series. Our speaker today is Keith Andrew Wailoo, who's the Henry Putnam University Professor of History and Public Affairs at Princeton University, where he teaches in the Department of History and in the School of Public and International Affairs. Professor Wailoo is former chair of history and former vice dean in the School of Public and International Affairs, formerly known when Lainey Ross was at the school as the Woodrow Wilson School. He is an award-winning author on drugs and drug policy, on race, science, and health in the US, and on history, health policy, and medical affairs more generally. His research, teaching, and public engagement has spanned a wide range of areas: opioids, pain care, drug policy, racial and ethnic disparities in health and disease, the ethical and social implications of genetic innovation, and I could go on, sickle cell disease and policy, tobacco marketing and things. In 2007, Professor Wailoo was elected to the National Academy of Medicine. He currently is president of the American Association for the History of Medicine. His book work has been incredible. His most recent book is called Pushing Cool: Big Tobacco, Racial Marketing, and the Untold Story of the Menthol Cigarette. That will be published in 2021 by the University of Chicago Press. Other books have included Pain, A Political History, published by Johns Hopkins University Press, How Cancer Crossed the Color Line, published by Oxford University Press, The Troubled Dream of Genetic Medicine, also published by Johns Hopkins, Dying in the City of the Blues, Sickle Cell Anemia and the Politics of Race and Health, published at the University of North Carolina Press. I could go on. There are many additional books. Professor Wailoo has written widely, as you can tell, on health affairs, history, and health policy, and has done so also for publications such as The Lancet, JAMA, The New York Times, The New England Journal, and the Journal of Health Politics, Policy, and Law. His research has been supported by grants and fellowships from the National Institutes of Health, the Robert Wood Johnson Foundation's Investigator Awards in Health Policy Research, and the James S. McDonald Foundation's Centennial Fellowship in the History of Science. At Princeton, Professor Wailoo teaches undergraduate courses straddling history and public affairs, and also teaches a course with the former president of the university, Shirley Tillman. His graduate teaching at Princeton is in the School of Public Health and International Affairs, focusing on identity, power, and policy, and controversies in health policy, as well as historical perspectives. Again, I could go on with his teaching abilities. Let me conclude by saying that we're delighted to honor and welcome Professor Wailoo to join us today. His topic today is entitled Inequities Unmasked: What Pandemics Reveal About American Society, from the Spanish Flu to COVID-19. Keith Wailoo, it's a delight to welcome you.
Thank you. Thank you so much, Dr. Siegler, for the expansive and really gracious introduction, and to Dr. Ross, Lainey Ross, for the invitation to speak to the those who participate in the MacLean Center series. As Dr. Siegler just said, I'm a historian by both temperament and certainly by training. And I'm always looking for lessons from the past in order to inform our understanding of the present, but also to guide us into the future. And so with your indulgence, I'd like to talk a little bit today about the present and also a little bit about the past and how they relate more intimately to each other than we might otherwise see. And it's in some ways an unprecedented year in the sense that we are suffering through a pandemic trauma like no other that most of us have seen in our lifetimes. It's reminiscent of the trauma of the 1918 flu pandemic, often called the Spanish flu. But it has hints of the economic shock that followed the 1929 stock market crash and the Great Depression. It has unmistakable resemblance to the social unrest in 1968 and throughout the civil rights era. And it also has resonances with other eras in which you see cries for new approaches to governance that we've seen in other societies across the world. So it's unquestionably a tumultuous year for the US and the world, and by any historical measure, and it's still unfolding. So it's somewhat hard sometimes to, in the middle of this turmoil and calamity, to actually give a talk on inequalities unmasked because they are in some ways still being revealed. But insofar as we can see those inequalities, they're captured, or at least insofar as we can see the trends, they're captured by heartbreaking graphs and charts like this. As we watch what had been called, mistakenly, I believe, the quote, best healthcare system in the world, struggle to grapple with the challenges created by COVID-19, the coronavirus. We've watched the costs in some ways of an impoverished healthcare system that has become impoverished and underfunded over many, many decades struggle with the challenges. And we've also seen failures of leadership in this ongoing challenge, whether it revolves around simple things like masks or more complex ones, contact tracing or coordinated messaging or agenda setting. And we're still in the midst of this story, watching a fall wave set in, steeling ourselves for what is to come, even as we hope for a vaccine, which will be a godsend to be sure, but it will also bring with it new challenges with for the equitable distribution. To date, of course, the ethical challenges that are fundamentally revealed in the COVID-19 crisis are many, certainly at the clinical level. We've seen rippling across states, first in the Northeast and West, and then in the South, and most recently in the Midwest and Western states spanning the Dakotas and Wyoming. We've seen debates about the proper principles upon which the rationing of care should be decided. And we've seen discussions about lotteries that may become relevant in the context of scarcity. So clinical ethics challenges have been many, and I don't have to tell you of what they have been. In terms of public health ethics, the New York Times from yesterday reveals many of the racial and ethnic disparities that we've now come to know as some of the fundamental features of COVID-19. Pandemics have always been revealers as well as accentuators of inequalities, and the New York Times headlines yesterday highlights the higher hospitalization rates for Latinx, American Indian, and African American populations, 4 times the rate of white groups, and identifies, quite thankfully, because often these disparities just get reported without going into the details, identifies the intersecting reasons, the higher positivity rates among these groups compared to whites, because of jobs in the food service sector, which put them at higher risk, work in home healthcare, which also put minority groups at higher risk, working in fields that are not open to non-remote labor, which also increase the risks of exposure, and also work deemed essential, as in meatpacking plants, and then of course also returning from those places of work to communities or to households in which multi-generations, perhaps 3 generations, live in one household in densely populated communities. It's these intersecting vulnerabilities that give us an insight into the background that shapes the disparate positivity rate, the disparate hospitalization rate, and also disparities in death. Some forms of the pain and disparities that have been characteristic of the COVID-19 crisis have been figuring prominently in our public discussions and in our politics, and yet others have figured less prominently, whether it is the challenge of working in meatpacking plants across the nation, perhaps in the Midwest, in places like Iowa, or the crisis in Navajo nations. And then sporadically, from time to time, we catch glimpses of what these disparities look like from state to state. For example, in early October, we saw data like this that highlighted that in Wisconsin, a state whose Black population is 6.1% of the state's population, experiences 8.8% of the COVID-19 cases and 17.7% of the deaths. Now, it's important to note that back in May, when I first looked at this data from Wisconsin, the percentage of deaths for African Americans was about 27%. So it's a changing story, but it's a story of really quite shocking disparities nonetheless. And these disparities raise really important ethical questions about the nature of essential work, and whether, if in fact essential healthcare workers should be prioritized for N95 masks, protective equipment. Wouldn't a society built on foundations of ethics also provide these protections to other workers deemed to be essential? That is to say, workers who are sacrificing themselves to feed the population or to ensure that the population is fed in these challenging times. Shouldn't the category of essential non-remote worker also be prioritized for PPE, for highly protective masks, but also looking ahead, prioritized for effective vaccines? So the ethical questions, the ethical challenges rippling across this pandemic year and carrying into next year have been many, and a lot of them focus on the distribution of resources equitably, who has been made the greatest sacrifices and whose sacrifices for the greater good should be prioritized when it comes to safeguarding their health. What we've learned about vulnerability is, in some ways, it's important to look at the last months and remind ourselves that what we've learned about vulnerability has been an unfolding story. That is to say, it's always great in retrospect to say we've always known this, but there are things that we are actually learning as we go. For instance, we are learning, as that New York Times article that I just quoted from highlighted, what you might call the sociology of vulnerability. That is to say that vulnerability is an intersecting sociological phenomenon, not merely about biology or biological difference. These are situated vulnerabilities. Living in a nursing home, for instance, where you work in a meatpacking plant, where you live, and how you move through society. It seems like a long time ago, but we've also learned a great deal about the thing we call asymptomatic transmission, which very early on, the early evidence suggested was unlikely, but it turns out to be a fundamentally crucial challenge, a particularly insidious virus that is, in fact, taking advantage, because of asymptomatic transmission, of the sociology of vulnerability. That is, taking advantage of a social system we've learned that asymptomatic transmission, about 1 month into this, right, is a particularly insidious form of spread because, of course, someone who is not showing symptoms is transmitting. If you're a bus driver, if you're living in an apartment with 3 generations, if you live in places where there is congested living, where you have to travel in an elevator to get up to your apartment, or through lobbies, or on public transportation. So while some people might say things like there's something different about Latino bodies or Black bodies, that it's important to understand that this particular organism takes advantage of particular kinds of social vulnerabilities. If you're elderly, diabetic, living in multi-generational households, living in New York City, where early on, which was a hub, not just of the virus, but a hub of international commerce. So more than race or ethnicity per se, it's important to understand how the sociology of vulnerability intersects with the particularly insidious problem of asymptomatic transmission to produce the kinds of outcomes that we've seen. And that's also accentuated by the kinds of institutions in which people spend most of their time. Prisons, prisoners in prisons, nursing homes, meatpacking workers, etc. I mean, I could go on. There's so many other kinds of things that we've learned over the course of the last 8 or 9 months about the utility and the ethics of mask wearing. And I'll come back to this really in most of my comments. The importance of maintaining a functioning public health system, which in some ways separates the US from other societies, whether it's in the East, China, Singapore, or across Europe, right? Arguably, one of the key differences is in our inability to control the virus by way of deploying an already existing robust public health system focused on testing, social system of tracing, isolation, mandates, masking, mandates, and national coordination. These are all things that are lacking in our society, which are much more prevalent elsewhere. So it's not that we're not capable of these forms of coordination. I just should remind you as a historian, we were perfectly capable of rapidly scaling up and distributing penicillin during World War II, or distributing polio vaccine during the 1950s. There's a way in which, you know, the way we've handled this is revealing not of our society writ large, but particular features of our society these days. The pandemic has also introduced us to new problems, like a new way of thinking, flattening the curve, a new language that's entered our vocabulary in public health, but also the power of both information and disinformation, the power of disinformation to disrupt all of these different dynamics. Epidemics have always been great revealers, and this is where I'll sort of spend a little bit of time talking about history, and what history can tell us about our challenges today, and then return particularly to the mask debate today. You know, a lot of these questions about epidemics and inequality are not new. Mortality trends in pandemics always reflect existing social inequality. So in his chronicle of the bubonic plague in 1665 London, Daniel Defoe observed that the infection kept chiefly in the out parishes, which being very populous and fuller, alas, of poor, the distemper found more to prey upon than in the city. And here you see the out parishes, really not the inner city, but the outer parishes being the place where the poor resided. This is an image not from the 1660s, but actually a Victorian era portrayal of the Great Visitation of bubonic plague. In the cholera epidemics in the US in 1832, in 1849, and in 1866, for example, there were fierce debates reminiscent of our own discussions about the wisdom of closing the ports, stopping commerce in order to protect the public and protect the public health. And there were those who insisted on allowing traffic and goods to continue regardless of the toll. So these kinds of debates about opening the economy or closing the economy in the name of public health are kind of recurring themes. Those epidemics, like today, were also shocking revealers of poverty, with New York City hit particularly hard in the first wave. First to be hit, especially because then as now, New York City was a national center of international travel and commerce. And yes, there was also blame. Blame for the high death toll, which fell disproportionately on the poor, in this case, Irish Catholics living in the Five Points neighborhood of New York, or Black citizens in the city. So as one commentator, a California man visiting New York City, said, the people, quote, inhabiting the most populous and central portions of the city were the most hard hit by the cholera. This is also a story that unfortunately comes up again in the wave of epidemics across the 19th century. Yellow fever epidemics raised similar questions about why some areas, particularly the southern states, were harder hit than others, with very little discussion and understanding about the role of mosquitoes in the spread. The experience with the flu pandemic 100 years or so ago bears perhaps the closest resemblance to the current coronavirus crisis. Here, the deaths in the US over 15 months of devastation climbed to nearly 700,000, with worldwide deaths in the tens of millions. As I mentioned, one of the features of epidemics has always been their capacity to inflame differences, to produce blame that can often be racialized, and fear and questions of security graphically portrayed. So I'll show you an image here that's not from the flu pandemic, but it's about 10 years before the flu pandemic, and it's meant to illustrate the threat posed by another epidemic disease, tuberculosis, and it comes to us from a newspaper in Atlanta, the Atlanta Journal and Constitution, which portrays the threat of a Black woman who is a domestic worker flying, as it would seem, from her home, flying the flag of contagious disease across a river of filth into the home in which she works. And that home, as this image, this cartoon portrays, has built up the most formidable modern defenses, the sanitary precautions, the screens, the pure water, the garbage cans, the modern instruments of hygiene, the good sewage, and also has been defended by medical science. It is flying the flag that's called the average white home, but yet it is vulnerable to an assault by this domestic worker who comes to the home every day to do her work. It's these images of racialized blame, fear, and the quest for, in this case, white security that recur in the history of plagues, whether we're talking about Jews being blamed for the plague in medieval Europe, tuberculosis, and indeed other pandemics past and present. So 10 years later, the flu came along, and it was called the Spanish flu. And there's always this element of blame in the naming, as we've seen this year as well. The Spanish flu, as it was called, was unusual for another reason in 1918. It coincided with a world war. And the movement of troops, in fact, fed the spread of the disease. As these headlines blared, the Allied forces were fighting Germans on one front, and the governors were fighting against invisible enemies on the home front. And with closed theaters, churches, lodges, and other establishments as their front lines. Then as now, masks were widely discussed, and then as now, the public was learning how to safeguard its health. Public warnings became a familiar aspect of the social landscape, warning to avoid droplets of spray from the nose. I mean, some of this seems like it's pulled from the headlines very early on in the pandemic this year. To cover your mouth when coughing, and they didn't do the elbow cough back then, but they were very, very conscientious about how to cough with handkerchiefs. Cover your mouth and nose when coughing, to avoid crowds, and also instructions on how to make a face mask, as described in the Milwaukee newspapers in 1918. Then as now, masks revealed an ideological divide. And seen through the lens of history, you see the tensions and fracture lines then and today as really a recurring narrative of, in some ways, distrust about government, but also kind of a story about the limits and the character of what might be called interpersonal ethics, as in what do we owe to one another in the midst of these calamities. These are, in some ways, a year ago, I might have given you this lecture and you would have said, what a strange society this is, that they would have such a debate. But today, this debate seems all too familiar. For example, let's take the discussion about wearing the mask. Some locales mandated masks, flu masks for everyone in public places, as in Grand Rapids, Michigan in December 1918, but others, as in San Francisco 1 month later, would see thousands of mask opponents denouncing the city's ordinance. These tensions remind me of the famous William Faulkner quote from Requiem of a Nun in 1950, "The past is never dead, it isn't even past." Let me pause for a moment to say a little bit about how to understand masks as both political, to be sure. That is to say, about how opposition to masks are really about opposition to government, but also an opportunity to talk about the power and also the extent of public health policing to mandate these kinds of behaviors in the name of public health. But also about how masks are a story about public health ethics, not only about the role of government and policing, but interpersonal ethics. That is to say, what do we owe to one another? And these are hard lessons that we've been learning over the course of months in a repeated fashion. Masks as a story about protecting yourself as well as protecting others. With the flu pandemic, we see ourselves, as this nurse looks at us, in historical retrospect, as both shockingly far away from these debates and then also shockingly close by. I'll come back to the mask in one moment. In 1918, you also see, long before hydrochloroquine, a society desperately grasping for new drugs, with flu folks rushing to drugstores in the midst of the pandemic and flourishing, and all kinds of specious theories flourishing, as in the run to the store for face atomizers, sprays, gargles, and germicides in Spokane, Washington. And we see, as pictured by a political cartoonist in 1919, the run on the pharmacy, with well-clad men rushing to buy ye old germ destroyer as the storm clouds of influenza loom over the horizon. And we find newspapers in every corner of the nation, like Denver, Colorado, crowing about the, quote, latest cure or preventive, like Wilson's solution. Just a few drops inhaled from the pocket handkerchief disinfects the nose and throat. Those who would profit from panic or from the spread of misinformation were everywhere, then as now. Then as now, freedom and economic livelihoods seemed at stake as society responded, and as cities policed mask wearing in the name of public health. So in Denver, officers were stationed at corners to restrict non-mask wearers from getting on streetcars, while the theater men in that same town protested the closing of their establishments, offering even to give out free masks if only they could be allowed to open. Looking back on these times, which only 8 months ago would seem bizarre and distant, we see ourselves in a new light. We see society, how to make and adjust a mask the proper way, looking at us even as we look back at them. And perhaps most shockingly, in an age of shocking virus deniers, stories today tragically pulled from our own newspapers of people who deny that the virus even exists, that it's real, you have stories like this in November 1918, while some coastal cities in the West grew restive, like Seattle, with protests asking that the mask rule and the so-called epidemic, it says, some Pacific coastal cities become restive under orders of health department relative to the so-called epidemic. While other Western cities like San Francisco, proudly seeing themselves as leading the charge with masks playing a big part in curbing the epidemic. Indeed, the city was also, that is San Francisco, was also aggressively turning its factories to the job of producing masks and hoping to lead the state in the production of a vaccine. It was doomed, this vaccine hope, alas, for there were very few tools in the medical sciences at the time to identify, isolate, and culture flu viruses, let alone produce a vaccine. That's a story that was really decades into the future. So it is that the story of the pandemic of 1918-1919 revolves not around gargles and vaccines, but really around the mask. And the verdict, not only at the time, but among historians who have studied the differences in death rates between cities, is that the mandated masks, closures, as well as social distancing, the differences between those cities that mandated masks, closures, and social distancing and those who did not is that the mask won the day. As the San Francisco Examiner noted in January 1919, which was nearly a full year after the pandemic began, at a time when cities continuously, obsessively charted the number of cases and deaths day by day, as we do today, they proclaimed that cities where mask wearing is compulsory showed a corresponding epidemic decrease. So we historians have a habit of looking at the past, and in so doing, we see the past looking back at us, quite literally in this case. In a broad sense, the nurses from the past, whether they're in San Francisco or Austin, Texas, have their eyes looking at us. So just to conclude with a few observations of what it is that they would see in us. Well, then as now, the controversies about mask wearing, which I see as a study, as I said, in interpersonal ethics, not just public health mandates or relational ethics, principles that guide our personal interactions, care, and respect for one another. The ethical debate about the relational ethics debate is, as I said, fundamentally about what we owe to one another. But for some skeptics of masks, masks are not about what we owe to one another. They understand masks as a muzzle. That is to say, perversely as a constraint on not only a public health mandate, but a constraint on their physical selves, on their bodies. And out of that has also emerged a set of rumors about masks as constraints on their ability to breathe, rumors refuted by the Mayo Clinic and others, particularly when they went, quote, viral in June and July of this year, which took it upon themselves to debunk a wide set of myths about masks. And those, particularly the one that said that people who wear masks are forced to breathe their own CO2, and that would result in them dying from CO2 toxicity. And in answer to these allegations, Mayo Clinic and others say myth, wearing a mask will increase the amount of carbon dioxide I breathe and will make me sick. The answer, the fact, there is no risk of hypoxia, which is lower oxygen level in healthy adults. Carbon dioxide will freely diffuse through your mask as you breathe. As I said, a lot of what's going on here are masks as seen as part of an ethic of social responsibility for some, as well as, and in some ways, the closest thing that we have to a vaccine before vaccines become available. It's hard sometimes to take the skeptics of masks seriously, but if we do for a moment, you begin to see a mindset that emerges that is worth considering. Because buried in these viral, so to speak, debates about relational ethics questions and questions about truth as well. And this leads me to reflect on what are called, as I said, relational ethics that are particularly germane to our crisis. But it also provokes me to think about race at this particular moment. Because on the one hand, there is a tension in those who refute the truth of what masks can do to protect themselves and really indulge in a fiction rooted in their own experience, which is, it is true that it is more difficult to breathe when you're wearing a mask. And that experience is extrapolated, in some ways gone awry, into the idea that it is a constraint on my ability to breathe, and therefore that masks inhibit my expulsion of carbon dioxide, and therefore masks are dangerous, and a mandate is tantamount to killing me. This argument was marshaled, cultivated against normative prescriptions to wear masks, and helped to legitimize the idea that mandates are not only an infringement on rights, but also a dangerous constraint on breathing. The laws on masks are thus a realm of applied ethics, you might say. They enshrine certain kinds of values of interpersonal responsibility into law and into the policing of public space. To be sure, there are huge variations, confusions, and even outright fabrications about masks, but the underlying ethical question is, to what do we owe allegiance when we create mask policies? Consensus, truth about how viruses move through material and air, normative pronouncements applied in the real world, or, to what extent do we cater to and indulge these sort of beliefs about masks that are really based on experiences gone hopelessly awry? But there is something fundamentally troubling for me looking at the mask debate, and I mentioned this in a talk I gave a couple of nights ago, and that is, to me, a lot of the mask debate, especially unfolding mid-part of 2020 amidst the protests over George Floyd's murder, raised the question of whose breathing matters in a pandemic and generally in these problems of relational ethics. Is it the grievance of people like this? This man is in Iowa at a protest wearing a sign that says, "Fear of COVID does not trump my right to not breathe my own CO2, a claim that most medical experts and others say there is no evidence for. But watching this mass debate unfold about, you are constraining my breathing against the argument that I can't breathe became a cry for respect for African Americans around the country and, in fact, people around the world. There's this deep irony here about whose breathing matters. Of course, there's in one image a kind of a picture of white grievance, which has predominated in our culture and our politics for many years. Perversely, this idea of masks as a deadly constraint on breath unfolded at exactly the time when you have marches of protests because a Minneapolis police officer held his knee on the neck of George Floyd for more than 8 minutes, which constrained his ability to breathe, a choking that is real and deadly and not imagined and speculative. And this has been going on starting really with Eric Garner many years prior. So the anti-maskers then are asking whose breathing matters, and in some ways they are repurposing the I can't breathe protest to try to draw attention to their own grievance. And so to me, this is a particularly deep irony of the COVID-19 year, our plague year, as it revolves around the question of not just whose breathing matters, but whose pain matters and whose breathing matters. And you reveal yet another kind of disparity, right? The disparity between Black righteous protest and white grievance about the perception of lost liberties, with sweeping implications for our relational ethics. So when I think about the inequalities, and I'll wrap up here, Unmasked in 2020, our plague year, our pandemic year, this is this one figures really prominently alongside the many others. In my last slide, what I want to do is to sort of point forward as to like, well, what do these inequalities tell us that we need to work at and work on as we pivot into a new year and a new administration? I think the challenges in the months and years to come will be many. I can't possibly begin to list them, but just based on what I've described, what I'd say is, there are a set of fundamental sort of simpler challenges, and there's some that are really going to take many, many years and may be impossible to solve. One is sort of beginning to work on a public health system, and you could just end there, just beginning to work on a public health system, but one that prioritizes something fairly simple, like prioritizing N95 masks for all essential workers, the people who are actually in harm's way. Reforming a public health system to prioritize the health of the most vulnerable, people whose afflictions really have never really been well addressed, people with diabetes and asthma, underlying factors in the COVID-19 mortality. And then I think we have the ability, because we have new coordinated national leadership on the way, not a moment too soon in many people's view, is to sort of move beyond the ethic of grievance to an ethic of decency, recognizing the fact, and you begin to see even some governors in the far west, in North Dakota and elsewhere, beginning to realize that masks are not about grievance, and they're not about selfish self-definitions of liberty, but they really are fundamentally about what we owe each other and making lives matter, and particularly in many places, Black lives matter. So I'll end there by kind of just giving you that list of the kinds of things that our pandemic has revealed about our American society, the challenges that it has revealed, but also the opportunities and perhaps the positive paths forward. So with that, I will stop sharing my slide and would be happy to take any questions you have.
So first, thank you very much, Professor Wailoo. That was an incredible talk. I'm just going to encourage the audience, they can put their Q&A in either the Q&A or in the chat, and we'll take those. I'm going to take the privilege of asking the first question. So masks are very much about relational ethics. The vaccine has both a relational component, but also very much an individual component. So similar. And as we're coming closer to a real vaccine, you've talked about who should be prioritized, and I'm not going to push you too much because, as you told us, you're a historian, you like talking about the past, not the future. Mm-hmm. But how should we deal with the fact that we have a lot of vaccine hesitancy?
So, the one thing I would say is, I think there was a study out today, in fact, that suggested that the public is less hesitant about this vaccine and growing less hesitant than it had even 2 or 3 months ago. So one of the things I would say is that there is vaccine hesitancy about illnesses that have disappeared from sight. So vaccine hesitancy about measles, for instance, is a kind of privilege that people can have based on the fact that they don't see much measles anymore. To me, the opportunity created by a COVID-19 vaccine is that I suspect that many, many people will want this vaccine because of the experiences they've had in their communities, in their households, and in their own lives of loss. So I'm actually interested to see whether what we think we know about vaccine hesitancy will manifest itself in the COVID-19 crisis. I mean, we have a society, the irony is you have, for instance, I mean, not to kind of talk about the outgoing president, right? But you have an outgoing president who has been sowing the seeds of distrust and misinformation about masks, but avidly hoping and promoting, the production of a vaccine. So so that tells me something, that we have a society that's primed to want a vaccine. Whether or not, now here's my concern, which is vaccines are never, they're always experiments, right? Public health experiments. They will produce, like the polio vaccine, there was one crisis called the Cutter incident that had a bad batch of vaccine that went bad. And the Surgeon General had to step in and reassure the public that they should still go ahead to be vaccinated, that we've gotten rid of the Cutter Labs vaccine. I'm not 100% sure, but there will be some misstep. The challenge will be to not allow any missteps to feed people's hesitancy and skepticism. So I'm actually optimistic that given just the massive toll of the coronavirus mortality, that the public is primed to really want this vaccine.
I sure hope you're right. The first question I'm going to take is from Gretchen Swarzy, who says hello, and she says, can you talk a bit more about what you mean when you're talking about relational ethics? I'm hearing it's about what we owe each other as fellow humans, but I'm struggling with how masks fit in. Aren't masks more like stop signs and streetlights, driving on the right side of the road? We do these things because they make us more free. If we stomp out the virus by wearing a mask, then we would be more free.
Yeah, I mean, I guess Gretchen is offering one other framing of a mask. The reason why I think they're about relational ethics is because fundamentally they're about how my breath is traveling and influences and affects your well-being. And so it turns something that previously is fairly inconsequential, as in I'm breathing on you, I'm too close to you, into a question of what is my relationship to you, and how questions of proximity and the way I interact with you are in some ways a judgment on my respect for you. And these other fundamental relational questions of respect, concern for your health and well-being, and when the mask debate discussion first began, it was, most people think about masks as me protecting myself. And it's taken a while for people to understand, not everyone understands it, that a mask are about me demonstrating that I'm concerned about your health and well-being, because my breathing may be a hazard to you. So Gretchen's characterization of a mask makes it more like a seatbelt, right? Where it's like, we all have a responsibility to wear seatbelts, and really they're mandates about me and my own health and well-being. What I'm arguing is that that's not a relational way of thinking about a mask. That's a kind of classic public health, social mandate. That, whereas I'm saying that what needs to develop is a more relational understanding of what a mask is. So she's sort of framing it as I don't want to put words in her mouth, but in a kind of classic, like the state commands for your health and well-being. And I'm saying, well, actually, a mask is more than that.
Great. You have a fan club here. Monica Peak says, excellent talk.
Monica.
The underlying assumptions for these relational ethics about whose pain matters and whose breathing matters is white privilege. How did we discuss these issues in the current national conversation? in a country that is already so polarized?
Yeah, I mean, so I mentioned a couple nights ago that maybe I didn't actually, that because I think of vulnerability as sociological, right? I also think of polarization as sociological. And I think that people often say the country is polarized, and I agree. But I think the country, there are social processes that make the country polarized. For instance, I think our parties feed polarization, right? I think that there's a lot that in the course of an election, elections really about polar opposite choices and always have been. The question is, do we ordinarily live our lives in a polarized fashion? When I look at things like, there's some who would like to make Black Lives Matter about one feature of polarization. But if you look at the people marching in the wake of George Floyd's murder and marching for Black lives, it doesn't look like an image of racial or ethnic polarization. It doesn't look like young people polarized against older people. It really does look like a broad sweep of people across age, across gender, and across race and ethnicity who have a set of principles that they're willing to march for. So I guess what I'd say is, polarization is clearly there, but we also need to look beneath the polarization to understand the places where people are coming together, bridging these kinds of divides and working towards the kind of unity. I'm not saying it's going to work, but it's there. It's there already.
Thank you. The next question comes from Sadie Solomon. How did government healthcare during previous pandemics counteract misinformation, and how did they reach the most vulnerable groups for prevention and treatment?
That's a great question. What I would say is the lessons are complicated of the past. The fact that we think of the federal government as a coordinating force for handling major public health crises is relatively new, because historically we've had a very weak federal government and a very strong state system. So in some ways, this kind of patchwork of governors and states doing things, this is how things worked in the 19th century, and it's how things worked for much of the 20th century. That said, each locality actually mobilized to respond to pandemics in ways that are forward-looking. So for instance, in New York City in 1866, this is one of the first places to produce something that we take for granted today, a Metropolitan Board of Health, as a permanent feature of city government, that says, like, we need to have an agency of government that's devoted to the public health. It took 3 cholera epidemics before that happened, but that has become a norm. And then you get state boards of health that emerged later on. So the idea that, the federal government should be able to coordinate these things, that's been true for, I'd say for the last 100 years. But at the same time, because we have this federal system where there's always this push and pull between whether the federal government is just a coordinator or a standard setter, or whether states really determine how these stories should play out, that's the kind of messy story of American politics. So I guess the short answer to her question is that there are lessons, but they tend to be state by state or locality by locality lessons that then are applied more generally. So here's a good example. Like early on in the pandemic, I live in New Jersey, and our governor imposed some pretty strict mandates because, of course, we were at the leading edge of the first kind of wave. And Governor Murphy would refer to people who didn't obey the laws as knuckleheads. He didn't say they were bad. He just had this phrase. And I just noticed the other day that in North Dakota, I think the governor there started using this language, right? Even as he mandated masks, which suggests to me, was it South Dakota or North? The 2 Dakotas are responding differently right now. But it's a good example of how slow, these practices can kind of migrate from one state to the other.
The Preston Reynolds writes to you, have you heard eugenic rhetoric that those who are being affected worst and dying most are simply genetically weaker?
I haven't seen specifically genetic language used to characterize, to both characterize why some are dying more than others, but I haven't seen eugenic language to justify why we should not do anything, which are two classic features of eugenics. But I strongly believe that that sort of thinking, which is an implicit prioritization and deprioritization of certain lives, has played a role in public health and kind of public policy. And I'll give you an example. I do think, and these are hard to prove and study, but I do think that the fact that the pandemic really started in New York City, right? The big, it started in the West and Washington State as well, and California as well, but you had this sort of big focus in New York City. And very early on, you had this image of racial disparities that were shocking. And I'm fairly convinced that that sent a message to people who live in North Dakota, South Dakota, other places that, well, we're not New York City. All the things that New York City has, we don't have. And therefore, it's not going to affect us. And so there's a way in which underlying, now, whether there's a eugenic thinking in there as well, as in that's their problem, you actually heard people, elected officials saying, that's a blue state problem, right? So there's definitely that. Whether it goes all the way down to eugenic thinking about bodies being more infirm, and that I'd have to study that a little bit more detailed.
It's interesting because if you take it 2 months back, it was happening in China. It wasn't going to happen here, right?
Mm-hmm.
And we were able to keep MERS and SARS-1 out of the U.S. So there might be even some, ethnocentrism about it. It wasn't going to happen here even before we get to North Dakota not believing New York is closer. The Leonard Slade asks, how do countries with national health care handle these type of situations and disparities different than the U.S.?
A lot different. And it's hard to generalize about all of them, but I'd say what countries with national healthcare systems and robust public health systems have is that they just have a wider range of tools to use. And they also have a public that is kind of oriented towards large-scale interventions in the name of the broad public health, even if you push back against them, right? So it's kind of the, so what I would say is that whether it has to do with closing an economy, but also ensuring people's welfare while the economy is closed, like those are tools that China has that we don't have, right? Which is because our system is simply not set up. So what we have is close the economy, send checks to some people who are, deemed to be vulnerable, but have a debate about how long we're going to send those checks because we want to put pressure on the system to reopen. So it's a really messy system that's very kind of, has robust government in a situational way. That's just one among many examples of the tools that organized sort of societies like that have. The one thing I want to go back to your comment, Lainey, about it won't happen to us. So Asiatic cholera was swept through Europe in the 18 teens, but it never crossed the Atlantic because the speed with which transatlantic commerce happened was not sufficiently fast to allow cholera to arrive here. It burned itself out on ships. So in 1831, when it also moved across Europe, people said, oh, it won't come here. And there was this conceit that America just didn't have any of the problems that Europe had. We didn't have big cities like London or Berlin or Vienna. We didn't have the kind of poverty that they had. And so we were like this literal city on a hill, and it would never get here. And so the shock of when it arrived in 1832 really made possible by the speed of transportation, right? So now you had transatlantic voyages moving a lot more quickly, and also the railroads and the kind of inland commerce, and people were shocked. And it really was a wake-up call that, like, you know, we're not the society we thought we were. And I think this is what's going on now in parts of North Dakota, Wyoming, Utah, South Dakota. What I'm surprised by is that it's taken so long to watch this story play out. But we're talking about 58% positivity rate in some of these, places where they're testing now. So it is, to me, a kind of recurring story of people who believe that they're privileged, they're special, and then realizing that, the virus doesn't care ultimately, how special you think you are.
Given that you talked about the speed, Dr. Mike Masol wants to know whether you'll fly on a Boeing.
I haven't flown anywhere. I mean, mostly because people aren't inviting me anywhere, but so probably not.
Dorian Miller, who runs our Center for Community Health and Vitality, says, when I speak to my primary care patients, primarily African Americans on the South Side, about a vaccine, they're extremely hesitant about taking the vaccine because of the antipathy expressed towards the African American community by the current president and the president's excitement about the vaccine. There's more concern about long-term issues plaguing the community and attention to poverty and chronic disease.
Mm-hmm. Well, I don't have much to say other than that's really revealing and interesting information, because it tells you that the messenger the messenger is as important as the message, and in some ways we are therefore greatly we're saved by having a new messenger who will ultimately take office, who has a certain element of credibility with people, and who also, well, with many people, not with everyone, right? But who, I think, the other problem is that, 3 or 4 days ago, you have a president who is threatening Governor Cuomo with withholding a vaccine because because he said things about Trump's handling of the public health crisis that are critical. So, one of the things we can look forward to is someone who has a broader understanding of ethics and equity, and who won't allow these kinds of judgments to cloud his thinking. So maybe that's a positive answer to that question.
Well, so it's interesting because Esther Berkowitz wrote, historically, what are the most frequent reasons for vaccine refusal? And then she adds on, and I think this is important, following up to what you just said, how does distrust of government compare with distrust of science or distrust of professional expertise?
Mm-hmm. Yeah. So there's distrust of government, science, and professional expertise. Yeah. So let me just say that this is a hard issue. And you might remember that the distrust was also working in yet another way until recently, which is that as the president was pushing FDA and other instruments of government to move ahead with a vaccine faster than the scientists thought was wise, there was also distrust building up amongst Democrats and liberals about the vaccine process, right? So, that is the idea that, like, if you push a vaccine out without following proper safeguards, how can we trust the vaccine? I think, what I'd say is, when you have these overlapping issues of distrust, distrust of government, distrust of science, distrust of professionals, the proof of the pudding will be in the eating, right? It will be the question of distribution, distributing the vaccine to the people who sign up for it, who are deemed to be most vulnerable. The data will drive, and people's experiences will determine and ultimately help to address some of these areas of distrust. And hopefully, if the vaccines roll out in a way that produce as little difficulty as possible, maybe we'll turn the corner on vaccine skepticism more generally, right? I mean, if these vaccines are what are promised, it actually may lay the groundwork for a very different conversation about what we can expect from vaccines going forward, right?
Mark, I see you're on mute. If you want to ask your question, please unmute yourself.
Yes, thank you. Early on in your superb talk, you spoke that our hope would be that vaccines will bring, and I think I'm quoting here, new challenges on fair distribution. And my question for you is what you believe will happen in terms of distribution to the vulnerable, that is the aged, those with different races, those with different employments of the kind that you refer to, and even those who live in circumstances that are of higher risk than others. Do you think that this fair distribution will happen?
So, I must say that this is a question that is fundamentally connected with the politics of the transition that we're also witnessing. If we had something that looked like a normal transition of power from an administration that has really pulled itself back from national coordination on any kinds of questions, let alone these, to a administration that clearly wants there to be not just coordination, but also wants certain principles to guide how we navigate our way out of this calamity. If there was a transition, I would be optimistic that between Moderna, Pfizer, and maybe 3 other vaccines that come into play, that we might have a system of coordination, of guidelines created by the CDC, of messaging that make it really clear, right, how states should navigate this and how the healthcare system should navigate this. But it is exactly that, to me, that's endangered by where we currently are, because what we are going to likely be facing is 60 days of intransigence and hands-off and sort of letting a system unfold without any guidance, without any ethical underpinning, without any coordination. And then a new administration that has to scramble. Now, what I hope, and maybe this is sort of me thinking about how politics works, I actually think that probably the Biden administration is working on this behind the scenes, right? I mean, this is not somebody who, he's been in government before. He has long since appointed people to kind of organize these kinds of policies. I would not at all be surprised to know that some of this conversation is going, even in the absence of the power to actually shape any of these policies. So that's my that's my hope without knowing anything. It's just it's pure speculation, but we got to hold on to something.
Thank you.
Your optimism, I hope, is contagious. John Ellis writes, in 1918, did regional mass protection decrease as regional local fatalities increase? So, for example, early in this pandemic, high rates of COVID-19 in Detroit led to mandates for the entire state, though at the time, COVID rates were low in northern Michigan and the Upper Peninsula.
Right. So read the first part of his statement again.
In 1918, did regional mass protests decrease as regional local fatalities increased? So as we hear about, our state, like right now, Illinois is running at 12,000 cases a day, our highest ever, and we're having our highest fatalities. Will that encourage both Chicago as well as downstate to listen to the governor, even if it's only in one part of the country, the state?
Yeah, I think that's basically, unfortunately, this is partly what I say about, there's this kind of interesting and difficult psychological story of the ironies of the public reaction to health crises, right? When, the reason why, in some ways, we live in a society where people can afford vaccine skepticism because we can sort of say all of those problems have been consigned to either the past or they're not where I could see them. But when you actually experience and see the problem, the psychology of prevention changes, because the irony of vaccines is for vaccines to work, nothing has to happen. That is to say, the bad thing, doesn't happen anymore. And psychologically, it's actually very challenging to convince people that these things are working when the evidence that they work means that your life just goes on as normal. So in some ways, when you have the shocking examples of rising rates, deaths, hospitalization rates going up, setting up field hospitals, it reminds people of what the stakes are. And it does encourage people to, in some ways, take the kinds of precautions. And that's partly why I remain optimistic about the COVID-19 vaccine, because I think that the psychological dynamic is a lot different than trying to sell a measles vaccine, let's say, or trying to sell, it was easy to sell a measles vaccine when measles was actually an experience that people had. It's a lot harder to sell it today for a variety of reasons, but part of the reason is that people just don't even know what measles is.
And in the pediatric world, we talk about vaccines being the victim of their own success. Mm-hmm. It's interesting, you keep talking about the rates. The one thing we've learned in pediatrics is the anecdotes are more important, right? Knowing somebody or having somebody in your town or a local church bulletin, putting an in memoriam from COVID will be much more powerful than any of the statistics that I can ever give. Mm-hmm. Mm-hmm. I'm going to take one last question, because then we're going to transfer over so that the fellows and some of the faculty may be able to have a more personal conversation with you. And the last comment I'm going to read to you is from Ibrahim Hazmat, who writes, on the topic of genetics, there was a lot of messaging online about Black people being immune to COVID, which led to many celebrities and news outlets to actively debunk those myths. I've heard that this talk about Black people's immunity to a deadly virus was something that was pushed in previous pandemics. Can you speak more to this and how this language has negatively impacted the Black community then and now?
Yeah. So unfortunately, there's a long history of both debates about Black susceptibility and Black immunity, as if racial biology, is the determining factor that explains either and in Black immunity, you saw that particularly play out in the yellow fever epidemics, starting in the 1790s in Philadelphia, where the idea of Black immunity actually led the city to mobilize Black people to both clean the streets, but also to transport the dead, and also to kind of come into the homes of people who were infected. When in fact, the data that you see says that there is no real phenomenon called Black immunity, but that persisted for almost a century, this idea. And in some ways, excuse me, there is you might say that there are phenomena. For instance, with smallpox, there's a classic story from 1721 where Cotton Mather learns from one of his slaves of a practice called variolation, which was used in Africa, where you kind of use the pus to inoculate, so to speak. And so there are things where you could think you're seeing immunity when in fact you're seeing some other kind of previous exposure, for instance. So but the idea that Blacks are either uniquely immune or uniquely susceptible are two kinds of biological explanations that often, I should say, come to the fore in the midst of these to explain disparities. And part of what I tried to do in setting up the talk is to point out that, in lieu of going to biological difference, there are so many obvious features of the social landscape of vulnerability that explain the differences, that let us not walk down the path of biological immunity on the one hand, which gives people a false sense of security, or biological susceptibility, which always carries this element of blame. And let's begin to kind of think through the sociology, because it's the sociology of vulnerability that's going to allow us to understand how you prevent this from happening, or how you address the difficulties that we're grappling with right now.
On behalf of everyone who's on the webinar, I want to thank you. That was a fabulous talk. I'm excited about your optimism, and I look forward to bringing us all into the small group. So for the students and faculty who are going to join, Professor Wailoo, Dr. Siegler, and others, we're going to take a 5-minute break, and we're going to reconvene at 1:25 Chicago time, 2:25 East Coast time on the other Zoom. Any last words, Mark?
No, I just wanted to thank Professor Wailoo. It was a spectacular talk and was very moving. And thank you for answering these excellent questions that have come up and answering them as clearly and articulately as you did. So our warm thanks.
Thank you.